Hello everyone. In 2024, after the extremes meet, the McDonald criteria for the multiple sclerosis has been updated. So today I am going to discuss step-by approach for the diagnosis of multiple sclerosis, and we will see what are the fundamental principles and what are the important steps that we have to take to make our diagnosis better and clear. So first, I would like to discuss the fundamental principle and the clinical foundation for the diagnosis of multiple sclerosis based on this current diagnostic criteria. The 2024 revision brings a paradigm shift. That means from longitudinal observation, now we are making the diagnosis of multiple sclerosis based on the biological understanding of multiple sclerosis. What does that mean? That means previously we were waiting for multiple attacks before making a diagnosis of multiple sclerosis. But now, based on these guidelines, as we have more specific biomarker and radiological tools to make the diagnosis even much more specific and better. So we can make the diagnosis of multiple sclerosis even after a single attack. And not just a single attack, we even can make the diagnosis of multiple sclerosis even without an attack. The condition known as radiologically isolated syndrome, where a patient who is incidentally found to have lesions suggestive of multiple sclerosis, but he does not have any symptoms, he is completely asymptomatic. Even in that case, can now diagnose them as a multiple sclerosis if the criteria is fulfilled. So the main important core diagnostic pillars of this guideline is unified framework. That means now these guidelines is applicable for both pediatric and adult population across all courses, both relapsing and progressive multiple sclerosis. Previously, diagnostic guidelines for the pediatric patient were different as compared to the adult population. Plus, along with that, the diagnosis of exclusion should be remembered. Because multiple sclerosis is the diagnosis of exclusion, we have to still exclude the other possible causes that can explain the patient's symptom or radiological findings. And now the paraclinical necessity. The MRI and CSF are now mandatory part of the diagnostic workup, not just supportive. Use of these advanced diagnostic tool, we have to be more specific. If we are diagnosing someone with single demyelinating event, we have to be sure about diagnostic specificity. So we have to use this MRI and the CSF biomarker, which are now available for use. And the new guideline is now globally applicable to all the country and to all the ethnicity and the races. So let's start on the diagnostic flowchart for the multiple sclerosis. In this diagnostic flowchart, first we will talk step-by approach for the diagnosis of this condition. The first step is the important one, where we have to understand the initial presentation. The multiple sclerosis can present in three different ways. One is acute attack, where patient present with typical or classical demyelinating event like optic neuritis, myelitis, or acute brainstem episodes. Plus, patient can have progressive episodes. Sometimes patient does not have any symptoms. He was found to have radiological findings suggestive of multiple sclerosis. This is known as radiological isolated syndrome. Even in that case, we can identify the patient to be multiple sclerosis. So, along with that, we have to understand what are the important mimics that we have to differentiate from multiple sclerosis. The most important mimics are NMOSD and MOG. NMOSD and MOG both present as long LETM, long segment myelitis. So long segment myelitis is myelitis which involve more than equal to 3 segments of the vertebral column. So both of these conditions present with long segment myelitis. Along with this, MOGAD is important to rule out if it is demyelinating event present in a children less than 12 years of age. Any children who is going to be diagnosed with multiple sclerosis, it is important to exclude the possibility of MOGAD in them. Other than that, MOGAD usually present with bilateral optic neuritis and Adam-like features in children. Apart from that, any patient who is more than 50 years of age or who have vascular risk factor like smoking, diabetes, hypertension, in all of these patients, we have to look for other specific marker for the further confirmation of the multiple sclerosis diagnosis. These specific markers include spinal cord lesion, lesion and CSF biomarker. So if a patient who is more than 50 years of age, if following criteria is not met, but the classical criteria for multiple sclerosis is met, we have to be cautious in these conditions. So coming to the second step of the diagnosis. The second step of the diagnosis is the most important step in the diagnosis of multiple sclerosis. In previous criteria, dissemination in space and dissemination in time both were important for the diagnosis of multiple sclerosis. But according to 2024 criteria, the DIT, now DIT is not absolute criteria. That means if DIS and DIT is available, yes, it is good, we can make the diagnosis of multiple sclerosis. But if a patient does not fulfill the criteria of DIT, still we can make the diagnosis of multiple sclerosis if he fulfills the DIS criteria and some other clinical picture, CSF biomarker or radiological features. Previously, there were only 4 anatomical sites for the identifying the DIS. But now, according to this guideline, according to this criteria, another 5th anatomical site has been added. And this 5th anatomical site is optic nerve. And lesion of optic nerve can be identified by using 3 separate tools. We can use MRI, we can use VEP, or we can use OCT. If you want to use MRI, we have to look for the fat saturation image in MRI sequences. If we are using VEP, we have to look for abnormal P100 peak or interocular asymmetry. If we are using OCT, which is optical coherence tomography, we have to look for inter-eye difference. The threshold is more than equal to 6 micrometer at the retinal nerve fiber layer. If these criteria are fulfilled, we can identify optic nerve as a 5th anatomical site. Other than that, the previous 4 anatomical sites are as it is. After identifying dissemination in space, whether it is present or not, we have to look for the number of lesions present in the MRI. So based on the number of lesions, we can identify the condition as a high lesion load, low lesion load. High lesion load is the condition. High lesion load is a condition if the patient have MRI lesions equal at least 4 anatomical sites. If patient has MRI lesion of at least 4 sites, in that condition, we can make the diagnosis of multiple sclerosis after a single attack. We don't need anything else to prove whether it is MS or not. We just need to rule out other possible causes. So this is known as high lesion load. Plus, if patient has single attack, but he does not fulfill the dissemination in space criteria, that means he has single attack. That means he has single attack and have only single MRI lesion. This condition is known as low lesion load. In case of low lesion load, we have to further confirm whether DIT is present or not, or CSF biomarker is present or not. Only then we can confirm further whether it is going to be multiple sclerosis or not. So if any one of them are present, if any one is positive, if patient is showing DIT, that then only we can look for any central vein sign or paramagnetic rim lesion. So if any one of these central vein sign or paramagnetic rim lesion present along with dissemination in time or CSF positivity, then we can confirm the diagnosis of multiple sclerosis in low lesion load cases. The low lesion load cases are that who have single attack with single MRI lesion. Now coming to the case where patient have single attack and he have 2 MRI lesion. 2 MRI lesion, that means he had lesion at the 2 distinct anatomical sites. So in that condition, we have to, if we want to confirm the diagnosis of multiple sclerosis, patient need to be confirm CSF biomarker. If patient have positive CSF biomarker, that means patient have oligoclonal band in CSF or Kappa free light chain in the CSF. Kappa free light chain is now quantitative test which is approved recently for the diagnosis of multiple sclerosis. After single attack, if patient has 2 MRI lesion along with CSF positivity, we can make the diagnosis of multiple sclerosis. But if CSF is negative, we can look for the central vein sign. If central vein sign is positive, then we can make the diagnosis of multiple sclerosis with single attack and 2 MRI lesion. Applying these criteria, we can remember it as a CHD. If a patient has 2 MRI lesion or after a single attack. C for central vein sign. If patient has central vein sign positive, we can identify it as a multiple sclerosis. Then C for we can identify CSF positivity. If with single attack 2 MRI lesion, patient has positive central vein sign, we can make diagnosis of multiple sclerosis. If patient after single attack 2 MRI lesion, if patient have positive CSF, then we can make diagnosis of multiple sclerosis. H is high density lesion. If lesion are present in more than 4 sites, more than equal to 4 anatomical sites, then we can make the diagnosis of multiple sclerosis. And D is for dissemination in time. If patient is fulfilling the DIT criteria, then after single attack and 2 MRI lesion, we can make the diagnosis of multiple sclerosis. So this is the most important step for the diagnosis of multiple sclerosis. And these points are even suitable for the diagnosis of the primary progressive multiple sclerosis. Now let's understand these new specific biomarkers which are present in the CSF or radiological biomarker. The Kappa free light chain hoga. This is now equivalent to the oligoclonal band but with more specificity. The threshold index is more than equal to 6.1 to confirm the intrathecal synthesis of the Kappa free light chain. This quantitative test and better than oligoclonal band. Then comes the central vein sign. Central vein sign suggests the lesion, the attack of the multiple sclerosis started just at the core of the central vein sign. And these are hypointense lesion of less than 2 mm center in the T2 lesions. To confirm positive central vein sign, we have to identify at least 6 lesions who have central vein sign. Or if the lesions are fewer than 10, then in that case 50% of, if 50% of lesion showing central vein sign, then we can say the lesion are positive for central vein sign. Then another important radiological biomarker, that is a paramagnetic rim lesion. These paramagnetic rim lesions are their discrete paramagnetic rim of more than 2/3 around outer edge of the T2 hyperintense lesion on SWI sequence. It must be seen on 2 consecutive slices or 2 orthogonal planes. That means lesions should be of appropriate size. And present of more than one paramagnetic rim lesion suggests 99.7% specificity for the multiple sclerosis. That is almost equal to 100%. Then coming to the step 5, where we will consider about the spatial population and radiological isolated syndrome. As we have discussed in pediatric population, this criteria is also applicable for the pediatric population. But we have to remember, if a child is less than 12 years of age, we have to rule out the possibility of MOG-associated disorder. MOG-associated disorder or Adam-like presentation. If patient age is more than 50 or if he have any vascular risk like diabetes mellitus or hypertension or history of smoking, in that condition, the presence of periventricular white matter lesion are common. So to rule out this doubt, we have to look for the definitive spinal cord lesion, and CSF should be positive in this group of the patient. So presence of these lesion will increase the specificity of our test. Then how to diagnose in case of radiological isolated syndrome. Radiological isolated syndrome are condition when asymptomatic patient who undergone an MRI imaging for some other investigation, for some other conditions, and found to have asymptomatic lesion which are similar to the lesion of multiple sclerosis. previously it was only previously in case of radiological isolated syndrome, the criteria were not clear to start whether to start disease modifying therapy or not. So in case of radiological isolated syndrome, if patient is fulfilling the criteria of DIS or DIT, then we can make the diagnosis of multiple sclerosis. Along with that, if patient is fulfilling the criteria of DIS along with CSF positive, we can make the diagnosis of multiple sclerosis. Plus, if the patient is fulfilling the criteria of DIS along with at least 6 central vein signs, so in that case, we can make the diagnosis of multiple sclerosis. So as I have suggested, the dissemination in space is the most important diagnostic tool or criteria that we have to use precisely or accurately. So for radiological isolated syndrome, we can say if patient has radiological isolated syndrome and here dissemination in space criteria is fulfilled, along with that, if any one of them is positive, if CSF is positive, we can make the diagnosis. If central vein sign is present, we can make the diagnosis. If DIT is present, we can make the diagnosis. So in case of radiological isolated syndrome, we have to just confirm C and D. D for dissemination in space, C for CSF positivity, and C for central vein sign. So after this, let's discuss the final summary. Availability of Kappa free light chain and central vein sign and high lesion load can substitute the DIT. That means in the presence of these biomarker, we have not to absolutely wait for the dissemination in time. That means we are making the diagnosis of multiple sclerosis very early. Then comes the specificity and sensitivity. Since we are making the diagnosis of multiple sclerosis after single attack, we have to rely on the very specific marker. And one of them specific marker is paramagnetic rim lesion. Presence of more than equal to one paramagnetic rim lesion is almost equivalent to 100% specificity. For further update, keep following our channel and share this video for your fellow neurologist or final year MBBS student who still want to understand the diagnostic criteria for multiple sclerosis.